a transplant hepatologist at UCSF. Her research is focused on finding ways to increase access to liver care for underserved patients and on developing strategies to increase screening for liver cancer. Thank you so much, Dr. Zheng, for joining us today to talk about viral hepatitis.
Thank you so much for the introduction, and thanks for having me today. So I decided to focus mostly on hepatitis B today, and mostly because there's going to be a lot of new research coming out about hepatitis B. And even this year, there's been some pretty good guidance recommendations and major changes in the way that we screen for hepatitis B. And now that we're coming into 2024, I decided to do kind of like a 2023 recap for hepatitis B, or a year in review. And so I'll add in some more recent publications, as well as recently presented abstracts from the liver meeting from just last month. So I'll start off with just the epidemiology of hepatitis B. No new changes there. But I'll focus on how we can help to eliminate hepatitis B, where our current challenges are. And then I'll shift into hepatitis B treatment. Not a lot of changes there, but a lot of new research coming out, particularly with regard to the future of hepatitis B with what we're treating. So some novel therapeutics for potentially curing hepatitis B, maybe in like the next 10 years. And then I'll end with screening for HCC. And I think that'll be a nice segue for Dr. Yao's talk about HCC later today. So just starting with epidemiology, we know that chronic hepatitis B is a global problem. And we see across the world that the hepatitis B prevalence rates vary widely. So in dark blue is where we see higher Hep B prevalence. So in certain parts of Central America, Africa, and Asia. And compared to the US, where we have relatively low rates, we see a pretty wide variability. And what that translates to in the US is that if we look a little bit deeper into population data, we see that actually a lot of hepatitis B still remains underdiagnosed. And that certainly we see that hepatitis B is more prevalent amongst certain ethnic groups. And that's not surprising because of the global variation. So if we look at data from 2013 to 2016, an estimated 2/3 of adults living with chronic hepatitis B were unaware of their infection. And then if we look at data from 2013 to 2018, the majority of people with chronic hepatitis B living in the US were non-US born. So these patients are 9.1 times more likely to be living with infection compared to US born patients. And then among the estimated 610,000 non-US born residents who have chronic hepatitis B, the majority of those patients are Asian, followed by 13.7% were Black or African American. And I think we can relate to that, especially practicing in the Bay Area. I think the majority of my patients with chronic hepatitis B are Asian. If we think about the impact of hepatitis B and why we actually care about hepatitis B, it's obviously because it has a lot of downstream effect. So you start off with the normal liver, you get infected with hepatitis B, which leads to chronic hepatitis. And unfortunately, chronic hepatitis can lead to HCC even in the absence of cirrhosis. And certainly we know that hepatitis B infection can lead to cirrhosis. Unfortunately, though, hepatitis B is labeled as a carcinogen because it can certainly increase the risk of developing HCC. And 70% of hepatitis B related deaths are due to HCC. So we have a lot of work to do in between here, between screening and preventing, and then, linkage to care here to prevent the development of cirrhosis. And then we have a lot of work to do for HCC screening to improve outcomes and to prevent HCC-related death. So knowing this burden of hepatitis B, several years ago, the WHO announced this goal to eliminate hepatitis B and hepatitis C by 2030. Being that it's only 7 years away, I think that's a pretty lofty goal at this point, but I think we're making some progress. So they're defining elimination as a 90% reduction in new cases of chronic viral hepatitis B and C infections by 2030, a 65% reduction in viral hepatitis B and C deaths by 2030, and a decrease in hepatitis B prevalence amongst children less than 5 years of age to less than 0.1% by 2030. And so how are we doing on that front so far? So this was recently published by the CDC. This is their 2023 viral hepatitis progress report for the US. And so we're doing pretty well, it looks like, based on 2021 data, and that we have been able to reduce the estimated new hepatitis B viral infections by greater than or equal to 20%. And we've been able to decrease the rate of new hepatitis B virus infections amongst persons who inject drugs by more than 25%. But we do have some room for improvement in terms of hepatitis B related deaths. We weren't able to really increase that rate of, or actually decrease the rate of reported hepatitis B deaths. And we have a lot of work to do, it looks like, in terms of decreasing hepatitis B related deaths amongst Asian and Pacific Islander persons. And so I think what this really points out to is that we have a lot of work to do in terms of linkage to care and HCC screening. So how do we go about eliminating hepatitis B? And I think that the overall theme, which I think you'll start to see in the upcoming slides, is to simplify. So in order to increase screening, we need to simplify our screening indications. In order to prevent hepatitis B, we need to increase vaccination, and therefore we need to make vaccination universal, again, to simplify. And then improving linkage to care. And I think that also boils down to really targeting communities and then simplifying treatment, which I'll also get into. So in the past, the CDC had all these guidelines about who you should be screening for hepatitis B, and you'd have to go back to these guidelines and like, okay, this person, is at high risk of having hepatitis B, so I'm going to screen them. In March of this year, they did away with all of these guidelines and they simplified, and they basically said that all adults who are 18 years or older should get this triple panel screening test at least once in their lifetime. And so the triple panel screening test includes hepatitis B surface antigen, hepatitis B surface antibody, and checking hepatitis B core antibody total. And so if you have a patient who has only gotten one of these tests, they're recommending that you just go ahead and get all three at this point, regardless of their risk factors. Pregnant women who, are pregnant need to be screened for hepatitis B surface antigen, regardless if they were vaccinated in the past or if they were already tested during another pregnancy. And then thinking about more routine screening for patients who have an increased risk of getting hepatitis B. So people who are incarcerated, people with a history of sexually transmitted infections, multiple sex partners, and then co-infection with hepatitis C. And then obviously testing anybody who's requesting hepatitis B screening, regardless of their disclosure risk. So what this boils down to is if you have a patient who hasn't been screened yet for hepatitis B, you should just go ahead and check all three of these tests. Or if all three of these tests haven't been checked at some point and one has, you can go ahead and complete the rest of the triple panel test. So that's screening, simplifying. Where we kind of need some more room for improvement is vaccination. So we've adopted universal vaccination for infants. So every infant who is born in the US is offered a hepatitis B vaccine. Recently, the Advisory Committee on Immunization Practices recommends that all adults get vaccinated for hepatitis B if they have not already been. And then adults who are older than 60 years of age and have risk factors for hepatitis B, or they want Hep B vaccine, should also be offered vaccination. The change in the guidance really came in just that if adult patients between the ages of 19 to 59 have not gotten a hepatitis B vaccine, they should be offered one. And this really came from kind of this data, in that we were seeing an increase in acute hepatitis B infections amongst younger patients. So patients in the age groups of 40 to 49 and the age groups of 20 to 29, they have an increased rate of acute hepatitis B infections over the years. And so these are obviously patients who have not yet been vaccinated. So the goal is to really increase screening, increase vaccination just by simplifying. Where I think that it's not so simple is linkage to care. And I think there's a lot of barriers to linkage to care, particularly with the population who is at risk for hepatitis B. For the next two slides, I've included abstracts that were presented at the liver meeting last month. And this is specifically looking at issues with linkage to care amongst communities who are at increased risk for viral hepatitis. And so what they looked at specifically in this abstract was Asian American populations, because data here is lacking. And this is a population who is at increased risk of having hepatitis B. And so what they wanted to do was they wanted to identify barriers and facilitators of viral hepatitis care amongst Asian American communities in Michigan. And they mostly, interviewed stakeholders within these communities. So they identified 11 community leaders from Asian American communities, Bangladeshi, Burmese, and Chinese communities, and they participated in semi-structured interviews. So this is kind of like a qualitative study that they did. What they found was that between all of these communities, there were shared barriers to viral hepatitis screening and care. And that included not speaking English, a lack of education, misinformation, lack of transportation, lack of insurance, their costs of care, stigma associated with viral hepatitis, fear of losing wages, and then lack of funding for outreach. And then what they found was that there were certain unique barriers amongst the Burmese community. So feeling that there was racism when seeking healthcare, multiple dialects within the community, and then multiple religious affiliations that further siloed this particular community. But in the end, their conclusion was that we really need tailored interventions to address specific community needs if we want to make improvements in linkage to care for viral hepatitis, as well as cancer outreach. Callie looked at another population of patients with hepatitis B, again, kind of focusing on linkage to care and how we can improve that. What she did, and she presented this abstract also at the liver meeting, was she looked at immigration factors and social determinants of health with regard to hepatitis B monitoring. It was a multi-center, multilingual survey amongst foreign-born adults with chronic hepatitis B in 3 sites in California and DC. There were 217 participants from 27 different birth countries. Interestingly, the majority of these patients were already US citizens, and only 29% had recently immigrated within the last 20 years. But the majority of these patients saw specialists for hepatitis B. 74% were already on treatment. 55% showed optimal adherence to monitoring over a median of 4 years. And what she found that were factors that were not associated with adherence were immigration factors, the degree of acculturation, and then language. So her study was actually a little bit different than the study that I just presented. But what she found was that there were social determinants of health that were associated with higher adherence rates. So younger age, patients who are already on treatment, patients who are currently employed and probably therefore had access to insurance, and then patients who had higher education levels were more likely to adhere to hepatitis B monitoring. And so her conclusion was that social determinants of health is what we should be focusing on, not so much, immigration related factors. And we should specifically target socially disadvantaged foreign-born patients if we want to improve hepatitis B monitoring. And so that's kind of like a little bit of a summary of our elimination goals are challenges, and hopefully we can certainly meet those goals of eliminating hepatitis B by 2030. Now I'm going to shift a little bit to talk about the natural history of hepatitis B. Obviously, no changes there, but I'll also talk about treatment indications. Not any published guidance changes, but I think that there will be changes in how we treat hepatitis B patients. Again, looking to simplify hepatitis B treatment. So I'm sure you guys have already seen this many, many times, looking at the different phases of hepatitis B infection. I'll mostly focus just on the development of chronic hepatitis B because that's what we're talking about in the context of treatment. And so we know that most patients who have chronic hepatitis B were infected at an early age. So the earlier you are, when you get hepatitis B, the more likely you are to develop chronic infection. We know that in the very early stages of hepatitis B, most patients are E antigen positive, which reflects a very high level of replication for hepatitis B DNA virus. And at that point, the ALT levels are high. But as these patients get older, we see that they go into this immune tolerant phase where, and this is usually when they're like in their 20s or 30s, and you'll see that their ALT is totally normal, but their E antigen is positive and they have really, really high hepatitis B viral loads. And then they kind of get older and in their 40s and 50s, you start to see their ALT levels start to go down. And along with that, their hepatitis B DNA viral load also starts to go down. At some point, they will seroconverge from E antigen positive to E antigen negative, and then they'll be in this inactive phase where their viral load is very low and their ALT levels are normal. And then as they get even older, we'll see that their ALT levels start to go up again. Their hepatitis B DNA viral load starts to go up again, and then they become in this active hepatitis phase again. And so it's really these two time points, this active hepatitis phase, where the traditional studies have shown that there's benefit in treatment. So again, when the ALT is elevated, and we see when the hepatitis B viral loads are also elevated. And I kind of wanted to show this study. I know this is definitely older, but I think it really drives home the point that high hepatitis B DNA viral loads are a problem. And we know that because the higher the levels are, the higher risk of cirrhosis and the higher the risk of HCC. And so we see that low hepatitis B viral loads less than 300, you have a much lower risk of developing cirrhosis as well as developing HCC. And then if we get to over 1 million, we see that the risk of cirrhosis and the risk of HCC really, really increases. And so that really, is a push to treat certain patients who have high viral loads. This is a figure that I'm sure you guys have seen as well, taken from the 2018 AASLD hepatitis B treatment guidance. This has not changed, and this guidance has not been updated yet, but I do think that in the next few years, again, moving towards simplifying treatment, I think this will change. And so this is kind of complicated in that, right now we're basing treatment on whether a patient is E antigen positive or E antigen negative. If you're E antigen positive and you have a normal ALT and your Hep B viral load is really high, greater than 20,000, there's no question, you don't necessarily need to treat in this point. But if your viral load is really high and your ALT is really, really high, like greater than twice the upper limit of normal, you should treat. And then if you're E antigen negative and you have a normal ALT and a low viral load, don't treat. If you have a high hepatitis B viral load greater than 2,000 and you have a high ALT, you should treat. But the question is what about these patients who are kind of in this gray zone in the middle where they do have high viral loads, which makes everybody anxious, and then their ALT is not necessarily 2 times the upper limit of normal, and they're kind of hovering in that 1 to 2 times the upper limit of normal phase. What should we do with these types of patients? Personally, I just treat them, especially if these patients are older. So like over the age of 40 or over the age of 50, I just treat these patients, mostly because we do have data that shows benefit for treating these patients. And then also it's just reassuring to not have to like keep checking their ALT levels to make sure that if it's above 2 times the upper limit of normal, then you'll treat. So personally, I just treat these patients in this gray zone. I wanted to show this data looking specifically at these patients in the gray zone. So this is data from the TORCH-B trial. This was a multi-center, double-blind, placebo-controlled randomized trial in which they randomized patients to getting tenofovir versus no treatment. They looked at patients between the ages of 25 to 70 with a viral load greater than 2,000. And all of these participants at entry had an ALT of 1 to 2 times the upper limit of normal. They excluded patients with cirrhosis because you definitely treat those patients. And then they excluded patients who previously had been treatment. And then they randomly assigned to treatment versus placebo. And then they looked at paired biopsies, so biopsies prior to treatment and then after treatment. What they found is that there actually wasn't a significant change in improvement of fibrosis stage amongst patients who get treated versus no treatment. But I thought it was interesting in that the patients who did get treated for tenofovir, they had a decreased proportion of patients who had progression of fibrosis. So I think that's worth noting. In terms of necroinflammation, they found that there was a significant improvement in necroinflammation on biopsy amongst patients who did get treated for hepatitis B. I bring up this study because it's one of the larger studies. It was a randomized controlled trial. And then also they recently presented updated data from a subset of these patients, again, at the liver meeting last month. And so this was an open label rollover study following the randomized control trial that they did, where they continued to follow these patients again after 3 years of tenofovir therapy. And they had paired biopsies also for these subset of patients. They were on the younger side, so 47, and most of these patients were men. But they found that in this group, after following them for an additional 3 years, that the severity of fibrosis significantly improved after years of tenofovir treatment. And then they also found that viral remission was achieved in 82.2% of patients, and 69% of patients had ALT normalization. And so with this data, I think that, again, it makes me more reassured that I am treating these patients who are in the gray zone. I think over time, we'll start to see the benefits of treatment. This was a study that was published by Doug Dietrich's group to basically simplify hepatitis B treatment. And I'm hoping that the AASLD guidance over the next several years will kind of go towards that because, again, we can only eliminate hepatitis B through improved linkage of care and through treatment, and that's how we can improve outcomes as well. So their proposal is that we should do away with E antigen positive, E antigen negative, and really base treatment on viral load and age, as well as ALT. And so what they're proposing is that if you have an older patient over 30 years of age and they have a high hepatitis B DNA viral load greater than 1,000, just treat them. If they're young and they have a high viral load and they have an elevated ALT, just treat them. If you have a low hepatitis B DNA viral load, you can defer and obviously a normal ALT. And if you're very young and you have a high viral load, but your ALT is normal, you can defer treatment. But I think the point that they were trying to make is that a lot of us actually see, patients who potentially who are 40, who have a normal ALT, but they have a somewhat high viral load. And in our current guidelines, it would say not necessary to treat. But I think that, these older patients always make us a little bit nervous. And so in this new simplified proposal, if you have an older patient with a high viral load, just go ahead and treat them. I did want to highlight that there are certain patients with hepatitis want to treat regardless of viral load and ALT. And so that's any patient with cirrhosis. Obviously, a decompensated cirrhotic needs to be treated for hepatitis B, regardless of their ALT and their viral load. This isn't like specifically stated in the current AASLD guidelines, but you can kind of infer it. So again, older adults who are over the age of 40, but have a normal ALT, but they have a really high viral load greater than 1 million, and they have a liver biopsy showing significant necroinflammation. And we usually don't do biopsies anymore for hepatitis B, but if they have a fibrosis stage greater than 2, you should just go ahead and treat those patients. And then obviously, if these patients have a diagnosis of HCC, regardless if they're cirrhotic, if they have a normal ALT or a low viral load, just treat these patients as well. So what are we treating with? Unfortunately, nothing has changed here. So the first line therapies that are recommended is still interferon, which nobody uses interferon anymore. Well, I personally haven't used interferon just because of the significant side effects, and also because our oral therapies are so good at suppressing virus. And so the oral therapies include entecavir, tenofovir, and the more recently approved tenofovir alafenamide or Vemlidy. Personally, I like to treat with entecavir or tenofovir alafenamide if you can get it. Insurance has been kind of stringent about approving Vemlidy these days, but I usually like either entecavir or tenofovir, mostly because we don't have to do a lot of renal monitoring. One important thing to remember is that if you have a decompensated cirrhotic on entecavir, they should be on the higher dose of 1 milligram daily. So once you start patients on treatment, how should you monitor? So for the first year, you should be checking liver tests and a Hep B DNA viral load every 3 to 4 months after you start treatment. I usually also check a surface antigen every year for patients who are already E antigen negative, and they have a persistently undetectable hepatitis B DNA viral load. I check because I'm just curious if they seroconvert from surface antigen positive to surface antigen negative. If you have a patient who is E antigen positive, you would want to probably every year as well check if they seroconvert from E antigen positive to E antigen negative, and they start to develop E antibodies. And then obviously patients who are on the older formula of tenofovir, so tenofovir disoproxil, you would want to monitor their renal function. I just want to touch on some special populations for hepatitis B treatment, including pregnant women. So if you have a pregnant woman who's interested in hepatitis B vaccination and has never been vaccinated, you could say that it is safe and efficacious in pregnancy. Amongst women who are pregnant, we always check a hepatitis B DNA viral load if they're not already on therapy in the 3rd trimester. If the viral load is greater than 200,000 international units, then we would treat them. And this is mostly to prevent transmission from mom to baby. If you're starting antiviral therapy purely for prevention of vertical transmission, then you can discontinue treatment at the time of delivery or up to 4 weeks postpartum. Tenofovir is still the treatment of choice, and breastfeeding is okay on tenofovir disoproxil. And so that's what the guidelines are still saying. But I know personally tenofovir alafenamide or Vemlidy has been used in pregnant women. Okay, so what to do once these patients deliver? So the current ASLD guidelines say that if these patients are on tenofovir specifically for prevention, you can discontinue treatment at the time of delivery or up to 4 weeks postpartum. And this is kind of based on data showing that if you withdraw therapy, but anywhere between 2 to 12 weeks postpartum, it didn't protect against flare. So it doesn't really matter when you stop, because actually most patients will flare. And this was highlighted by, again, a 2023 abstract that was presented last month at the liver meeting. They looked at hepatitis B virologic relapse amongst women who stopped tenofovir early versus late. And so this was just a single center study performed in China. It was 330 participants. And what they looked at was if you stopped tenofovir early, which was immediate, so right after birth, versus late, so equal or after 4 weeks after delivery. And they found, and this is similar to the larger study that was done several years ago, they found that virologic relapse was nearly universal. But they didn't see any significant difference in ALT changes, clinical relapse, or the need for retreatment. And there was no maternal to fetal transmission. So again, safe to stop treatment again, either at birth or several weeks after. The other special population are those who are immunocompromised. So patients who are surface antigen positive, who are not on treatment, but are about to begin immunosuppressive therapy or cytotoxic therapy, those are definitely the patients who need to be started on treatment to prevent reactivation and flare. The gray zone, or this is what we get a lot of e-consults for, is if this patient is surface antigen negative, but core antibody positive, so they were exposed to hepatitis B in the past, and so therefore they have risk for reactivation when they're immunosuppressed. Should we or should we not start treatment? A lot of it can be case-based. You can potentially do on-demand therapy, which is you can monitor their ALT, their DNA viral load, and their surface antigen every 3 months. If they have evidence of reactivation, then you would start them on treatment then. Usually, I only do this for patients who really don't want an additional medication, unless they're getting rituximab or they're undergoing stem cell transplant. Their risk of reactivation is really high, so those patients automatically get prophylaxis. And prophylaxis is the same as treatment. So with entecavir, tenofovir disoproxil, or tenofovir alafenamide, you would want to continue prophylaxis for 6 months after the immunosuppressive therapy stops, or at least 12 months after you stop, say, rituximab, because reactivation can occur up until a year. And actually, I've seen up until 2 years after stopping rituximab. So a little bit more about hepatitis B treatment in terms of when to stop. So I think the first question that anybody asks me when I start them on treatment is, when can I stop this? And my answer is usually never. But the patients always want to know when they can stop, especially if their surface antigen their viral loads are undetectable for a long period of time. So our goal is to get them to functional cure, which is when their surface antigen goes from positive to negative. That is the goal, and that's where we want all of our patients to be at when we potentially stop treatment. You could consider stopping treatment when they seroconvert from E antigen positive to E antigen negative, and they have a undetectable viral load, but the vast majority of those patients will reactivate. So the current treatment endpoints include when they convert from E antigen positive to E antigen negative, and their viral load is undetectable, and they have normal ALT for at least a year. You could consider stopping therapy. But again, the majority of these patients will reactivate and might require treatment again in the future. So I don't stop then. some patients will ask, okay, well, my viral load has been undetectable forever. Can I stop treatment? No, I don't stop treatment, especially if their surface antigen is still positive. And then really, and I've only seen one patient this happen for, is if they lose their surface antigen, so super, super rare. Um, and their hepatitis B viral load has been undetectable and they've had a normal ALT for at least a year, then you could consider stopping therapy. But again, this is super rare. And I wanted to show you how rare this was. This is a table taken from the AASLD hepatitis B guidelines, basically showing that for E antigen positive patients, the percent of surface antigen loss on treatment across the board ranges from 1% to 8%. And so if you have a patient on Viriad or Vamlidi, the rates are quite low, higher in interferon, but nobody gets treated with interferon these days. And then the rate of surface antigen loss is even lower amongst patients who are E antigen negative. So again, surface antigen loss is super, super rare. So I think that getting to this functional cure, which is surface antigen loss, is quite rare and not very achievable with the current therapies that we have now. So what's coming down the pipeline? So there's a lot of clinical trials that are in kind of phase 2 at this point, looking at many different medications, looking at surface antigen loss, and that's really where we're headed. I didn't want to do 10 slides on all these different phase 2 trials, but I did want to point out one medication that has gotten the farthest and has, I think, the most promising data. This was a study published earlier this year in the New England Journal. Bepirovirsen is the medication for hepatitis B. So this is an injectable medication, subcutaneous, that's weekly dosed. This is an antisense oligonucleotide that targets all hepatitis B messenger RNAs and acts to decrease levels of viral proteins across the board. This is part of the Be Clear study group, and what they looked at was if they could achieve surface antigen loss with only bepirovirsen or bepirovirsen plus an oral antiviral therapy. And their results, I think are promising. So they basically followed these patients for a total of 24 weeks. At the end of 24 weeks, they found that patients who received bepirovirsen plus an oral antiviral, 12% of these patients were able to clear surface antigen. And then amongst patients who only got bepirovirsen, 14% was able to clear surface antigen. And so obviously we would hope that this percentage is much higher, but I think, this is just the start of hopefully in the next 10 years, we'll get better and better and better at achieving surface antigen clearance. The Be Clear study group just presented their more abstract at the liver meeting last month, looking at new data, whether or not if you added bepirovirsen plus interferon, if that would help to decrease surface antigen levels at all. Unfortunately, they didn't find that adding interferon was significantly beneficial in decreasing surface antigen. But what they did find was that it was helpful in preventing relapse of hepatitis B if these patients got interferon after they got bepirovirsen. So basically what they showed is that about only 9 to 15%, so this was 9% of patients in the first arm and 15% of patients in the second arm were able to achieve sustained hepatitis B surface antigen clearance and Hep B DNA viral load being undetectable. What they found is that patients who had a low baseline surface antigen to begin with were more likely to achieve surface antigen loss. And the study here demonstrated one severe adverse event. So, and that happened when the ALT increased. So far, this treatment is safe. And then lastly, I'll end with screening for HCC. And so, I'm sure you guys have seen this guidance already. Nothing has really changed here in terms of this guidance. So a subset of patients with chronic hepatitis B are at increased risk of developing HCC. So obviously any patient with cirrhosis needs to get screened for HCC. If you have a family history, a first-degree family member with HCC, an Asian or African American man over the age of 40, Asian women over the age of 50, or if you have co-infection with hepatitis D. To be honest, clinically, if I have an Asian man who's like 35 and has active hepatitis B, I start screening just because, it's kind of hard for me to say, okay, let's just wait 5 years until you're 40 to do an ultrasound. And what if we see a 5-centimeter lesion at that point? So I kind of just start screening. And I think for older patients who are not Asian or African American, I also start screening too, especially if they have additional risk factors for HCC. So for example, if they also have a concomitant diagnosis of hepatic steatosis, I also kind of start screening them as well. How do you screen? I'm sure you guys already know this. So we screen every 6 months because HCC doubling time is about 3 to 4 months. So if we do screening every 6 months, we'll hopefully catch that HCC if it's growing. We use typically ultrasound. That's what the AASLD is recommending, with or without AFP. Although if you screen with ultrasound and AFP, the sensitivity goes much, much higher. You'll find that in our clinic, we usually alternate between ultrasound, CT, and MRI every 6 months. I don't personally do that actually. The patients that I usually alternate ultrasound and CT or MRI with are those who have cirrhosis or who have a higher BMI, and so their body habitus is they don't get as optimal images for ultrasound, so that's when I start to alternate. But if you have a patient who you think is relatively low risk and you get good quality images on ultrasound, I think it's also okay to do ultrasound every 6 months, definitely with an AFP level, because a lot of patients don't want to do CT or MRI because so that ends my talk. I'll end with some key points that Hep B is definitely underdiagnosed at this point, but hopefully diagnosis will increase because we are screening all adults now. And we're also recommending vaccination for all adults or patients who are at risk who are older than 60 years. We know that treatment for hepatitis B is very effective now for suppressing viral load, for reversing fibrosis, and preventing HCC, but surface antigen loss is rare. And so that's where our new therapeutics are looking, is for functional cure to lose surface antigen. I think there might be some possible new recommendations or guidance for treating chronic hepatitis B patients in this gray zone where this ALT is 1 to 2 times the upper limit of normal and they have a high viral load. It kind of just makes everybody nervous. But just remember that all cirrhotics or all patients who have HCC, regardless of their viral load and their ALT levels, need treatment. I think in the next 10 years, we're going to start to see a lot of new recommendations or actually new literature about novel agents for hepatitis B. I think the one agent right now to kind of keep an eye on is bepirovirsen. This, again, has gotten the best data so far and has gotten the farthest. But I think there will be a lot out in the next 5-10 years. And then just don't forget, obviously, to screen for appropriate patients for HCC. Question.